Hi, hello, greetings everyone. This is Dr. Dilip. I think you can hear me and see me because I'm looking on the phone here. I think I started this streaming right now. I'm looking on the phone here. I think I started this streaming right now. So hi there. Looking on the phone here. I think I started this streaming. Hi, are you there, people? Yeah, somebody can put a thumbs up button so that I can see. Yeah, hi Parag Sharma. Yeah, I can see you. So I think there is evidence that people are there, so that I think we can start with the session right now. So the case I want to discuss is on a very interesting case which I've seen a couple of days ago, because in this week I've scheduled sessions and YouTube sessions and special classes completely based on the cases which I have seen in the last week. So just I thought that really does make some sense, because I really like it, because evaluating a case is what matters. Last week I was in the COVID ward. Before that I was in the non-COVID duty, and this week again I was in the non-COVID duty, so that we take shifts alternatively. Anyways, like these are the cases which I have seen in the non-COVID ward. So that is a reason I want to discuss about these cases. So it was a pretty interesting one. It was a very rare one, in fact. So, but still, we'll be discussing on the basics of these cases as well. So let me tell you details of this case in the first place. Just 1 second. I'll just put it on with the this thing. Yeah. Keep the phone to my side so that I can answer your questions as well. Okay. So case was, I'm going to give a sequential analysis of the case so that whether you'll be able to make a diagnosis or not is a question. So it's a 54-year-old gentleman. This was the case, and he came to the emergency at around 2 a.m. The timing here is, I don't think how much it's important. It's not important though, according to me. So 2 a.m. with altered sensorium. So this was the history we got. So altered sensorium. No, like we didn't get any other significant history. He didn't have fever, no fever. If you think about meningitis, no neck stiffness, no headache, no vomiting, absolutely no problem. So all these things clinically doesn't tell you it's a meningitis, to be honest. So this altered sensorium, it's not sudden. So it was starting slowly, like it was progressively, gradually progressing over a period of maybe 1 to 2 days. Maybe he told about some 36 to 40 hours. I'm writing just 1 to 2 days. Initially, there was subtle changes in the behavior. Slowly, it changed to overt altered sensorium, overt altered mental status within a couple of days. So this was the history we got. This is the only history we got. Apart from that, the attenders did not have any other issue at all, to be honest. So what we are going to do here, to be honest. So this was the history. There's absolutely no problem. So when we took a, routine profile, renal function test. Routine renal function test. The renal function test showed absolutely normal, except for a borderline creatinine of maybe 3 milligrams per deciliter. So this was the creatinine we got, to be honest. So maybe it increased progressively in a couple of days to 1.7, 1.8, but apart from that, we didn't get any history at all. And this patient has a medication history, past history. He was a known case of coronary artery disease. He underwent maybe angiogram 10 days ago for the same. Angiogram 10 days ago. This was the medication history, and he currently was on aspirin, clopidogrel, atorvastatin, obviously on a high dose atorvastatin, like approximately around 40 milligram of atorvastatin is taking, clopidogrel of 75 and aspirin of 75 is on. And apart from that, he is also diabetic. For that, he is taking some sulfonylureas like gliclazide. He is also taking metformin. He is also taking gliptin called teneligliptin. This was the drugs he was taking. Apart from that, he also suffers from tension type headache. So he takes over the counter paracetamol for that. Paracetamol. And occasionally, he takes clonazepam for sleeplessness. Occasionally, once in a while. So this was the past medication history. So this is the only history we got. Apart from that, he didn't have any other history. So at this point, what do you think the case will be? So anyone can answer. So why the altered sensorium and what the case should be, and why the case? Why you think that, and you have to substantiate your answer. If yes, you can answer in the comment box, or if not, I don't know, Nikhil, what do you mean by so late? The session was late, or the patient came late? No idea. Send it. Infarct in brain. Yes, you want LFT, uremic encephalopathy. So let me tell all the other RFTs for now. So let us discuss one by one. So people wanted to give a differential diagnosis of atheroembolic disease, cortical vein thrombosis, Lewy body dementia. Okay, it doesn't present this acutely. There's no altered sensorium out there. GRBS. No, I don't know what is GRBS. Are you thinking about GBS or GRBS? CT scan. Yes, obviously. That's what we planned. RFT people who tell uremic encephalopathy think that the urea is absolutely normal, maybe in the borderline high range around 48 milligrams per deciliter, not much. I don't think at this urea you should have altered sensorium anyways. So urea is just 40. Normal urea is somewhere around 15 to 45, so it's just 40. It's just borderline elevated. I don't think this should and must cause altered sensorium. And his electrolytes were normal. Yeah, some people want random blood sugar. Correct, good. So you need random blood sugar. Yes. Oh my god, why it's not working? YouTube sessions are always problematic. Yeah. It's very slow. I don't know why the streaming. For those who comment on random blood sugar, let me tell you the random blood sugar. The random blood sugar was. Just hold on. Like there is, you usually like the streaming problem is there with some technical glitches does happen. So that's why I was a little bit worried about this. OBS. Just hold on. His random blood sugar was normal. His random blood sugar was approximately around 129. So this was his random blood sugar, which means it's normal. So it's not altered sensorium due to significant hyperglycemia. So it's really making a mess. Okay, fine. So his LFT was normal with mild increase in bilirubin. Maybe like somebody answered correctly. LFT was normal. LFT, the serum bilirubin was approximately like maybe 1.8 milligrams per deciliter, borderline increase, but not much. If you really want to know the indirect fraction and direct fraction, indirect was 1.5 around. I'm not very sure. Direct was approximately around 0.3. So this was the fraction. So this can happen in many conditions. Even a patient who's having a Gilbert syndrome can get this condition. It doesn't really mean anything. So this is something which is fairly normal. But anyways, this gives a significant amount of clue as well. So do you want to do anything else to the patient? So CT brain, you asked for CT brain. CT brain was completely normal. There's no problem at all. No, in fact, CT brain was completely normal. Even we progressed ahead and did an MRI brain with an MR angiography and MR venography, so which was again normal as well. MRI brain with MR angiography. Past history of seizures? No, not at all. Patient was not a case of seizures, anyways. We did MRI brain with MR angiography as well as MR venography. It was normal. Just hold on. So I'll try to close my tabs a bit. There's some streaming issues out there. So I don't know why. The internet is good here. It's getting really messy out here. Okay, I think now must be fine. MR angiography with MR venography, which look completely normal. Angiogram side effect for malarial parasite, any significant findings in the CBC? Yes, we did a CBC. We did a CBC. CBC was showing a hemoglobin. Yeah, step by step, I wanted you to answer. That's why I'm not telling anything. So, hemoglobin was there was a significant drop in the hemoglobin because we had a history of that angiogram which was done maybe a couple of days ago. Maybe after the angiogram discharge, they did a CBC. That time, hemoglobin was a nice 14.6. Now, hemoglobin was only around 8.2 grams per deciliter, which was significantly low. So it was dropped dramatically from the previous value of 14.3. So there was some ongoing active anemia in this patient. So what do you think now? So let us compile the findings. So CBG normal, electrolytes normal, yes, electrolytes normal, uh, CT brain normal, MRI normal, hemoglobin drop, serum bilirubin borderline increase, serum creatinine 1.43, and urea may be borderline at 48. So these are the abnormal reports which I have boxed. Apart from that, everything, these are the things that are normal. Apart from that, the entire LFT was normal. The liver enzymes were normal. OTPT was normal. So oxygen saturation, it's not hypoxia. Patient was maintaining a nice oxygen saturation of 99 percentage. I think at 98, 99. So this was the case. Apart from that, we are planning to really, put this case report ahead because it was one case which I have seen very, long back. So now we went on with evaluating with ECG. Patient had ST elevation in leads 2, 3, and AVF. 2, 3, and AVF. So it's confirmed. The patient was taken for a repeat coronary angiogram. It was a myocardial infarction. It was definitely a myocardial infarction. It was an RCA occlusion, and PTCA was done to RCA. PTCA was done RCA. RCA near complete occlusion, 99% occlusion to RCA. So PTCA was to RCA was done, and this was the case history. After 2 days, patient's hemoglobin further dropped. So patient's hemoglobin become now 6.1 grams per deciliter, and the patient's platelet count was just 26,000, and the serum creatinine was 1.61 milligrams per deciliter. It rose to from 1.3 to 1.6, and serum bilirubin was 2.4 milligrams per deciliter with indirect at 2.1 and direct at 0.3 still. So still, I mean, now you want to make a diagnosis. Yeah. So somebody is telling HUS TTP here. So yeah, this is true. It could be HUS-TTP. I'm not denying the fact. But can you tell me why this patient should develop HUS-TTP? But I mean, to develop this HUS-TTP, I have to, I mean, confirm this. I have to do some other investigations as well. But can anyone tell why this patient should have developed or would have developed this HUS and TTP? Suppose if you think in terms of if you think in terms of HUS and TTP, okay. So what are the investigations you have to do? What are the next step of investigations? I mean, which we failed to do, which we should have done, or which we have done and the reports have not come yet. Okay, number one is like I have to go for the peripheral smear, definitely. So we have sent the peripheral smear, and they have seen occasional cystocytes. I don't know how much it's specific because anything more than 0.5 is the one that is specific, but they have seen around 0.4 to 0.5 percentage of cystocytes, and they mentioned as occasional cystocytes are seen, and there was a gross anemia, gross decline in the RBC count, but other counts were normal. Okay, in the peripheral smear. Number two, but no malarial parasites were seen. MPMF was negative. They didn't see any malarial parasites. The patient didn't present with fever anyways. So after that, I have to do a D dimer, which is really important, and I have to do a PT, APDT, INR as well, which is again important also. PT, APDT, and INR. So what else I have to do? So what is the finding you will expect in a D dimer, PT, APDT, INR if you suppose consider a HUS-TTP complex? What do you expect? What do you expect the patient to have in D dimer, PT, APDT, and INR if the patient is having a HUS-TTP? No, this patient's D dimer was normal. This patient's D dimer, PT, APDT, INR was completely normal. So peripheral smear showed cystocytes, and we are sure about this patient is suffering from a TTP because the clinical picture profile was very similar to TTP. So because the patient present with altered mental status, which is a neurological issue, and patient had an anemia, and in the peripheral smear we had cystocytes, plus at the same time we have elevated serum bilirubin, majority or indirect fraction. It's clearly telling that the patient is having a microangiopathic hemolytic anemia, and patient is having elevated serum creatinine, so which is rising from 1.4 to 1.6 probably, and this patient is also having thrombocytopenia, low platelets. So it is fitting into the picture of TMA. So still I cannot confirm that this patient is having a TTP or HUS. So this patient is having a TMA, thrombotic microangiopathy. We know the triad of thrombotic microangiopathy. I think I've discussed this thrombotic microangiopathy session in one of the YouTube sessions a long back. So thrombotic microangiopathy is where you get microangiopathic hemolytic anemia. You have thrombocytopenia. Along with this thrombocytopenia, you tend to have a end organ failure. And this end organ failure can be anything ranging from kidney issues to neurological issues to even gastrointestinal issues, GIT issues. Clear? So this could be the case, and this patient is absolutely fitting into the picture because he's having MHA, he's having thrombocytopenia, he's having a neurological damage, plus or minus he's having a kidney issue also. But kidney issues is not yet sorted out because this kidney issue, I don't know whether it is atherembolic disease, because the patient had a history of coronary angiogram, so it could be atherembolic disease, or a patient could be having a SIN, contrast-induced nephropathy, or it could be TMA-induced kidney injury also. But we don't know what is the cause, so I'm not very sure that the patient is having what is the reason for this kidney injury, but definitely neurological issue is there. But it's not a stroke. Thrombocytopenia is there, microangiopathic hemolytic anemia is there, so definitely it's a TMA. There's no doubt about that. No doubt about this TMA. So this patient, I'm going to do a D dimer, PT, APDT, and INR. So when we did a PT, APDT, and INR, it was completely normal. So this completely normal PT, APDT, and INR should and must substantiate the fact that this patient is suffering from a HUS-TTP complex rather than a DIC. So it's not a DIC because Now my diagnosis of DIC is ruled out. So it is definitely a HUS TTP complex for sure. So if it's a HUS TTP complex, then I want to find out whether it's a HUS or a TTP. So we wanted to do an Adams 13 levels. The case came like 7 to 8 days ago. Adams 13 levels. So generally Adams 13 levels have less than 5% tells you it is probably a TTP, and Adams 13 level of more than 30% tells you likely it's a HUS. But the range of 5 to 30% is a gray area. We really don't know whether it is HUS or TTP. 5 to 30% is a gray area. We don't know. But this patient's Adams 13 levels came. It was approximately around 32%. This was the Adams 13 activity. So, many people would naturally think it's an HUS, but I don't think this patient is having an HUS. This patient is actually having a TTP. And this was a very quite complicated but interesting case because you need all these things to get correlated, because the Adams 13 levels were too costly, because Adams 13 levels really do cost around like 70K for the patient, almost 70,000 single test Adams 13. But fortunately, the patient was affordable to do this test. So we could make out, and at the same time this didn't give any clue also. The patient did question us regarding what is the purpose of this test, because even though we thought it's a the reports come like it's an HUS, but it's not HUS, it's definitely a thrombotic thrombocytopenic purpura. So here there is no other trigger for a thrombotic thrombocytopenic purpura, and the patient being having normal Adams 13 levels cannot have a congenital thrombotic thrombocytopenic purpura as well. So it must be something else. Obviously, we have discussed in the previous thing. So he had an angiogram 10 days ago. Following angiogram, he started with clopidogrel 75 milligram. And these drugs are unknown to cause thrombotic thrombocytopenic purpura. Atorvastatin impossible, aspirin impossible, but definitely clopidogrel is the one that is the culprit over here. But it doesn't have any history, no past history of seizures. CT brain was normal. Symptoms and signs are not suggestive of any delirium or meningitis, to be honest. So our only possibility right now is clopidogrel induced TTP. It took a while to understand this, but still. But we also have to rule out one important thing, that clopidogrel resistance, because we have to rule out this as well. Clopidogrel resistance. So because clopidogrel resistance is something which can itself lead to MI, a new MI. Clopidogrel resistance itself can lead to a new MI. So how will you rule out a clopidogrel resistance? Because patient was started on clopidogrel. So can anyone tell how to rule out a clopidogrel resistance causing a myocardial infarction? If clopidogrel resistance is the key, then your whole diagnosis of TTP becomes a joke. So I have to rule out clopidogrel resistance as well. So which means I should be sure that the clopidogrel works well enough to cause a TTP. So because this patient had a MI at the time of presentation. So can anyone tell how to rule out clopidogrel resistance? In the modern era, if you give clopidogrel or any maybe ticagrelor or any P2Y12 inhibitor, I given the clue already how to rule out resistance. No idea. So have you heard of, I think many corporate hospitals are doing, have you heard of this P2Y12? Called as PRU, P2Y12 testing, that's called P2Y12 reaction units. P2Y12 reaction unit. So this is what is implicated in many tertiary hospitals nowadays to find out whether the P2Y12 inhibitor that you give works correctly or not. Because P2Y12 inhibitors, there are different group of drugs, So what are the different group of P2Y12 inhibitors? Initially, it started with ticlopidin, but ticlopidin was banned because of its side effects. Then came the clopidogrel. Then you have the modern generation drugs like prasugrel. Then you have ticagrelor, cangrelor, and many other new drugs are also coming in this group. So ticlopidin we don't use right now. Clopidogrel is still very commonly used. In fact, clopidogrel is the only drug that is approved to use in stroke, coronary artery disease, and acute coronary syndrome. It is supposed to be used in peripheral vascular disease. This is the only drug till now approved for use in all these conditions. But prasugrel, ticagrelor, cangrelor, it's approved to use only in ACS, not anywhere else. You cannot use in stroke, you cannot use in peripheral vascular disease. Recommendation as of now. But still, these drugs are very effective. To be honest, prasugrel, ticagrelor, and cangrelor are very effective. And they can cause, if they are having increased action, they can cause bleeding also. If they are having less action, you can even result in thrombosis and recurrent MI and instant thrombosis and different complications because of poor action of these drugs. So to find out the P2Y12 action, you need definitely certain important studies like PRU. That's called P2Y12 reaction units. Normally, we don't know the exact PRU, even though the studies are going on. But in our hospital, we keep a range of 275 to 350. This is supposed to be the therapeutic range of PRU. This is a therapeutic range, 275 to 350. Anything more than 500, we consider increased risk of bleeding. Anything less than 250, we tell the patient is an increased risk of thrombosis and resistance. So we do have a marker to do a clopidogrel resistance and this P2Y12 action as well right now. It's a very new thing. I think it's been there for maybe for 4 or 5 years, but in India it was available in the last 1 year. So we have been increasingly using this. So I have to rule out this clopidogrel resistance because you might be thinking it could be MI induced. Probably some people have discussed it's hypoxia and pulmonary edema because of the patient could have presented with delirium. So this is a very high possibility. So I have to rule out why this MI has happened. So now our patient, when we did the PRU, in our patient the PRU was in the nice 335. So it means it's in the therapeutic range. So which means the patient was not at risk of thrombosis. So which means at this PRU, the patient should not have developed this myocardial infarction in the first place. Obviously, this patient should not have developed myocardial infarction. 100%. There is absolutely no doubt about that. So because it's in the therapeutic range. So now I have ruled out clopidogrel resistance as a cause of myocardial infarction. So that is the reason why when the patient developed a second MI, the cardiologist never used P2Y12 inhibitors. He did not use P2Y12 inhibitors at all. He instead used only GP2B3A during a this thing. And he used only aspirin. And he used heparin. So these are the things he used for stenting. He never used a P2Y12 inhibitor because we know that this P2Y12 inhibitors rarely can cause TTP, and this patient's clinical background was like a TTP. So we don't want to take a chance with the P2Y12 inhibitor again. So we avoided the P2Y12 inhibitor during the PTCA because we had this diagnosis back in the back of our mind. So we didn't give the P2Y12 inhibitor at all. And the cardiologist did the angiogram and the stenting was successful. And this was the case. And this was a very interesting one and it's very convincing now. So let us summarize the findings because during a clinical course, it's always better to keep track of the findings that we had right now. So initially, the patient came with altered mental status. We have ruled out a stroke. Patient didn't have a hypoxia, no hypoxia, and patient didn't have a seizure. Patient didn't have an infection. So because by the history, the CBC was normal and the counts were normal, so it's not suggestive of an infection. And next, I didn't tell you this point, we did a COVID-19 result also, it was negative. So let me tell you one thing, there are multiple trials which tell that COVID-19 is associated with increased risk of MI as well as increased risk of stroke. And there are studies which have been done in countries like Italy and China, which clearly told like COVID-19 incidence was very high in stroke and MI patients during the time of epidemic in their countries. So that is the reason why we want to do a COVID-19 because we want to rule out COVID-19 related MI and stroke. Because COVID-19 is angiocentric. I mean, it's been proven. The latest Lancet article has been, based on the autopsy, clearly told that COVID-19 is completely angiocentric and it damages the vessels. It causes significant endothelial injury. So that is the reason why COVID-19 is different from routine influenza strains. So now the case is clear. So we have ruled out infection. It's not COVID, it's not seizure, it's not hypoxia, it's not stroke, but the patient had some element of altered mental status. So now the patient had a renal injury. So let us summarize the findings. Renal injury with the serum creatinine that is progressively increasing from 1.43 to 1.61, I guess. And patient had a new myocardial infarction, new MI, and patient had a thrombocytopenia as well. And patient had a anemia as well. Anemia as well. It was a significant drop at 14.3 at the time of angiogram to 6.32. Uh, 8.1 to 6.3. So this is a significant anemia, and this anemia is likely a microangiopathic hemolytic anemia because of the because of increase in bilirubin. You are from class 10. Why you are here? So increase bilirubin, and you can also have wants to become a doctor. So this is not the place to become a doctor, dear Ishan Sharma. This is a place for people who have already become a doctor, and people who have already become a doctor like me itself is struggling with practice, and you are in class 10 and you want to learn this. Quite interesting. Okay, so increase bilirubin. Okay, thank you, Ishan. Thank you. Bye bye. So why people are having if this patient is having increased bilirubin, Ishan has distracted me a lot. Sorry. So people, this patient is having increased bilirubin, at the same time he's having more of an indirect fraction, and he's also seeing cystocytes. So these are the case summary. So this is definitely a case of a TTP, and we know that Adams 13 levels were normal. Adams 13 activity is normal, and the D dimer PT, APDT, INR was completely normal. And this patient is having a COVID negative Upshaw-Schulman syndrome. So let me come back to that. So in Upshaw-Schulman syndrome is a congenital Adams 13 deficiency. So definitely Adams 13 activity should be decreased in this case. So then only we can call it as Upshaw-Schulman syndrome. It's a congenital deficiency of Adams 13. So this case is definitely not a congenital deficiency. That's why I told you in the beginning itself, Adams 13 level normal indicates it's not congenital deficiency of Adams 13. And remember why we still diagnose a TTP here. So let me tell you why we have diagnosed TTP, and I'll tell you the treatment that we have done in this patient. This patient underwent steroid therapy with methylprednisolone. We started with 500 milligram OD. It's a high dose. I agreed to that. So, but we didn't have any other option to stop the falling platelets. This patient received methylprednisolone 500 milligram OD for 3 days, and along with that, he went for plasma exchange for 5 days, 5 sittings. And post this methylprednisolone plasma exchange, his platelet value was 1.47 lakhs. His hemoglobin improved significantly to approximately 11.2 grams per deciliter, and cystocytes in the peripheral smear disappeared. Cystocytes in the peripheral smear disappeared, and serum creatinine normalized at 1.1 milligrams per deciliter, and his altered mental status was resolved. So this was very clear, and this patient is having a TTP. There is no doubt about that, because TTP is the place where you have a very good response to plasma exchange. So even though according to entrance exam specs is considered as the treatment of choice, but majority of the times it's not always possible to differentiate between a TTP versus HUS most of the time. So this is the course of the patient. So we diagnosed a TTP which is likely clopidogrel induced. We are not very sure though, but likely due to clopidogrel induced thrombotic thrombocytopenic purpura, and treatment worked well with plasma exchange, and the case completely resolved. So it's not clopidogrel resistance, it's completely definitely TTP. There is no doubt about that. So let us go and discuss what you see in the TTP in the first place. HOS and TTP. So whenever you have a thrombotic microangiopathy, I've discussed this already, I think in one of my old YouTube sessions. Just I want to discuss this case. This was a very difficult case to handle, because at the instance, the diagnosis is what the key here, because we have started very early plasmapheresis for this patient on day 3 itself. So that is the reason why we could find out this clopidogrel induced TTP. Otherwise, if you have delayed the diagnosis, this is a quite fatal condition, and most of the patients will die within maybe 5-6 days if you don't treat them very fast. So triad of any thrombotic microangiopathy, you will have a microangiopathic hemolytic anemia, you have a thrombocytopenia, and as I told you, you'll have an end organ damage. So the most important differential diagnosis for this thrombotic microangiopathy is one thing, you have to rule out a DIC, and you have to diagnose a HUS TTP complex. So DIC, you know very well the D dimer definitely will be elevated, and all the other things like PT, INR, APTT will be elevated, obviously. So all these things, if it's normal, you're going to think about HUS-TTP complex. So our patient had all these things. He had microangiopathy, hemolytic anemia, he had a low platelet, he had an end organ damage in the form of altered mental status and high serum creatinine. So definitely this patient is suffering from with a normal D-dimer means is suffering from a HUS-TTP complex. But microangiopathic hemolytic anemia, there is some role for cystocytes as well. So what will be the usual cystocyte percentage in normal peripheral smear? What is the normal cystocyte percentage in the peripheral smear? I think I have told this data already, but still I expect some answer from you people. Normal cystocytes, any idea? Less than 0.5. Yeah, that's correct. So normal cystocytes I can write as less than zero point 0.2, to be honest. Normally less than 0.2 percentage is normal, but you can upgrade up to less than 0.5, which is okay, to be honest. But less than 0.2 is the usual normal thing. This is the usual amount of cystocytes you generally see. Anything more than 0.5 percentage is clearly abnormal. This now in the peripheral smear is clearly abnormal. And usually in TTP, the values will be more than 1 to 5 percentage. Usually in TTP, it will be more than 1 to 5 percentage. But this patient, that's why I told you, our patient had cystocytes of only, I think, 0.4 to 0.5 percentage. That's why they told occasional cystocytes, not really, going towards the TTP picture. But we do see a lot of atypical TTPs like this. But no need to worry about this. So this patient has a TTP for sure. So everything is going towards HUS TTP complex. Once you know it's HUS TTP complex, the most important thing that you have to see is the clinical background, not your Adams 13 levels. Even though Adams 13 levels will tell you that the patient is suffering from HUS or TTP, but most often it's better that you see a clinical background rather than a laboratory background. So I can see the laboratory also. The clinically HUS will present with the same triad, but you'll have microangiopathic hemolytic anemia. You'll have definitely low platelets, without a doubt, thrombocytopenia, and predominantly more of an renal failure. That's what HUS usually presents with. So usually the serum creatinine at presentation will be more than 1.5, and usually it will be in the range of 3 to 4. And major times this HUS happens in children. Does mitral valve prolapse murmur increase or decrease on afterload increment? So this is not related to the current discussion, Abbas Goyal. I think I have to discuss in a separate way that will completely stop the flow of the current topic. So I'll be discussing later on, not now. Anyways, microangiopathic hemolytic anemia, low platelet, and serum creatinine more than 1.5. And usually the thrombocytopenia will be less severe. Usually the platelet count will be more than 30,000 at presentation. And the serum creatinine usually will be more than 1.5 at presentation in case of HUS. And majority times this HUS happens in children. It does happen in adults in case of an atypical or complement HUS, but in general it happens in children usually. So this will be the clinical profile. So altered mental status are generally very, very rare, and the CNS involvement is very rare. And most of these children will have history of bloody diarrhea because it's toxin induced, right? Most of the children will have history of bloody diarrhea because this is toxin induced. It is caused by something called enterohemorrhagic E. coli, which produces this Shigella-like toxin that's called STEC E. coli, Shigella-like toxin producing E. coli, the O154H4, O157H7 and O104H4. And there are two strains which are very notorious for the same. So these are two strains, even though O157H7 is a very commonly encountered strain in clinical practice. So these are the usual background. Suppose if you call about this atypical HUS, this atypical HUS we call it as complement HUS. This complement HUS presents almost with the same finding, but it happens in adults, and majority of them will not have history of bloody diarrhea. So they can rarely have, but they really do not have history of bloody diarrhea, majority of them. So we can rule out that. So these patients also will be presenting with microangiopathic hemolytic anemia. These patients also will be having thrombocytopenia, and this patients also will be having serious high creatinine that more than 1.5, and this patient's platelet also will be more than 30,000. But altered mental status is fairly common here. Altered mental status is fairly common, so it's not rare at all. So that's why we call it a complement HUS or atypical HUS, where it is due to some problems in the complement pathways. So this is what the profile in the complement HUS. So how the TTP will present clinically? Again, they have the same TMA triad. All these things are going to have a normal D dimer. So they are going to present the microangiopathic hemolytic anemia. They will present with a low platelet thrombocytopenia, but usually the platelet will be seriously low here, less than 30,000. In our patient, this goes towards TTP because the platelet that we encountered at the initial point is only 26,000, isn't it? So it was very low. So definitely this patient had a thrombocytopenia. And along with that, there will be end organ damage. Typically, altered mental status is the most important. The CNS damage is the most prominent one in case of a thrombotic thrombocytopenic purpura. And serum creatinine will be less than 1.5, which means telling you that the kidney damage will not be that severe in case of a thrombotic thrombocytopenic purpura. In our patient, we had a serum creatinine of just 1.43 at presentation, even though it fits into the history of fever. Yeah, you might have a history of fever. Why not? So it's not like history of fever doesn't change the diagnosis here. Anyways, so this is what you have to see. So this is what the TTP is. So this is how they present. So our patient mostly clinically itself, they fit into this TTP picture, right? So they clinically fit into this TTP picture. Why they fit into this TTP picture is the fact that they have microangiopathic hemolytic anemia, platelet was very low at the presentation, serum creatinine was okay at presentation, and the patient typically present with neurological complication, that is altered mental status. So clinically, even though the patient is having a normal Adams 13 levels, my diagnosis will be thrombotic thrombocytopenic purpura. How will you treat? Remember this. This is called a typical HUS. This typical HUS that happens in children is typically treated conservatively. We don't do anything. Platelets, all these things are contraindicated really, unless and until there is real chance of severe bleeding. In those settings, we can give a platelet, but apart from that, we don't really give platelets. So it's truly supportive management in these cases. And whereas in a patient who's having a complement HUS, you can probably treat with eculizumab plus or minus a plasma exchange. So eculizumab generally works very well for these patients because it's a problem in the alternate complement pathway. That's why it's called also complement HUS. So in those settings, if you prove that it's a complement HUS, you can try eculizumab. But in case of a thrombotic thrombocytopenic purpura, you know very well the patient will be treated with plasma exchange as a main therapy. So this is the major therapy. In all this HUS TTP, eculizumab is an anti-C5 drug. In all these cases, so whatever may be the case, in all these three cases, remember, try to avoid platelets. No need to give platelets, okay? So try to avoid platelets as much as possible because platelets will worsen the scenario further and further by causing more platelet aggregation and endothelial injury. So try to avoid platelets. But exception is unless severe bleeding. So if you are encountering severe bleeding that warrants platelets, then you can give platelets, no problem. But unless and until severe bleeding, do not give platelets in these patients because that's very important. One of the important contraindications for platelet administration, if you take a lot of textbooks and see, one of the important contraindications for platelet administration is this HUS and TTP. In DIC, you can give platelets, no problem. But in HUS and TTP, it's better to avoid this platelet transfusion. So what about this clopidogrel induced? Is it very common? This clopidogrel induced HUS and TTP. Is it really common? So there are some occasional case reports. This is my personally second case of clopidogrel associated thrombotic thrombocytopenic purpura. Last case I have seen in approximately, I think something else happened. So last case I have seen approximately on 2016, I guess, around November or October. That's the last case I saw. This is the second case I'm seeing that is clopidogrel associated. Clopidogrel associated thrombotic thrombocytopenic purpura. So that's what is happening here. So a lot of other drugs also has been implicated, like your cyclosporin. We does have seen some cyclosporin and tacrolimus related. So these cyclosporin and tacrolimus are we know this belongs to this calcineurin inhibitor group, so they can produce, and these P2Y12 inhibitors have been implicated. A lot of cases have been implicated with ticlopidin, and a lot of cases have been implicated right now with clopidogrel as well. So this is my personal second case, but this is a rarity. You don't get it very often. And one of the important differential diagnosis for P2Y12 inhibitor-related thrombotic thrombocytopenia purpura is you have to rule out the resistance to P2Y12 inhibitors as well. That's why we did the PRUs, which was in the therapeutic range. That's why I've ruled out this P2Y12 inhibitor-related TTP as well. Apart from that, many other drugs are there which can implicate, but these are the two common things that you encounter in clinical practice. But if at all it's supposed to be a P2Y12 inhibitor related thrombotic thrombocytopenia purpura, how fast you will encounter? How can we figure DIC and clotting related deficiency? So if it's a DIC, I clearly told, right? So your D dimer must be elevated. There is no alternative for that. Your D dimer must be elevated in a DIC. Without elevated D dimer and your fibrin degradation products, it's very difficult to diagnose a DIC. I don't think it's a DIC. And clotting related deficiency, thrombocytopenia. No, it's obviously I've ruled out DIC, so it's not a clotting factor deficiency by any chance. So if it's a clotting factor deficiency, or PT, APT, INR must be elevated. Something must be elevated. So here it is normal, so it's unlikely to be a clotting factor related problem as well. So that's why I clearly told D dimer, PT, APT, INR must be normal to proceed towards a diagnosis of HOS and TTP. Otherwise, it's unlikely. So P2Y12 inhibitor, how fast you will develop? So usually this P2Y12 inhibitor related TTPs usually we develop within 2 weeks. Usually clopidogrel related TTPs will come within 2 weeks, and our patient also perfectly fits into the same, because I told he was done with angiogram 10 days back and he was started on clopidogrel just 10 days ago, and the patient came with altered sensorium over a period of 1 to 2 days. So which means it's very clear that our patient also followed the profile that is usually seen in other patients, like they presented within 2 weeks. This is a very classical case, and cyclosporin tacrolimus induced TTP usually will happen within 1 week after starting. So these timings are also very important. Usually after 1 week, calcium inhibitor related TTPs are generally very rare, and this P2Y12 inhibitor related TTPs are also generally very rare after 2 weeks. Usually they happen within a very short span after starting these drugs. This cyclosporin and tacrolimus associated TTP is common after a renal transplantation. So usually, it happens within 1 week after renal transplantation after starting one of these drugs, cyclosporin or tacrolimus. So the timing is also very important. These are all very important questions also for the exams, which have been asked in the past and it will be asked in the future also. So these are some of the basic background details of HOS and TTP. Our patient had very, perfect fit into that, and that is why we have treated these patients with plasma exchange in the first place. And if you have any questions, we can take on this case, because this is a case and you might have come with some differential diagnosis as well. So I want it to be a little interactive session. So I'll give 5 minutes for discussion about this case if you want. Any other differential diagnosis you want to come out with, so that we want to rule out, we want to ask this, so that it will be more interactive. Okay, somebody has asked about Upshaw-Schulman syndrome. So it comes under TTP only. Usually TTP, we know it is due to ADAMS 13 deficiency. ADAMS 13 activity, reduced ADAMS 13 activity rather than a deficiency. This reduced ADAMS 13 activity can be due to congenital reasons or could be due to acquired reasons. Congenital reasons usually happens in 1/3 of the patients. It's less common. That's what we refer to as Upshaw-Schulman disease. And definitely patients should have reduced ADAMS 13 activity, Upshaw-Schulman disease. And acquired ADAMS 13, reduced ADAMS 13 activity is usually due to antibody formation against this ADAMS 13, very commonly due to conditions like SLE. So that's where you get this reduced ADAMS 13 activity, where SLE itself can produce TTP like picture. So that is very quite common as well. Apart from that, one important thing that you have to notice, there are some drug-induced TTPs, drug-induced thrombotic thrombocytopenic purpura, which may have a normal ADAMS 13 activity. I'm not telling normal. ADAMS 13 activity is variable in these patients. ADAMS 13 activity is variable, and especially with both the cases I saw, 2 cases I have seen till now, with clopidogrel associated TTPs. In both these cases, I have found out that Adams-13 activity is quite normal. So that's why studies and reports have tell that Adams-13 activity is quite variable in this scenario. So it's unlikely to be due to have a diagnosis because of Adams-13 related level. So that is why it's not of any use. Obviously, I felt a little guilty personally because of wasting 70,000 of the patient's money. But if it is suppose low, suppose if the Adams-13 activity was less than 5%, we could have made a clear-cut diagnosis of TTP. But still, this patient is having only a probable TTP based on the clinical features and their response to plasma exchange. Apart from that, I cannot make a diagnosis of TTP concretely unless until Adams-13 levels are less than 5%. So my diagnosis of TTP here is completely clinical, and the treatment response, the plasma exchange did treat the patient extremely well. So that is the reason why I did think about TTP as a primary diagnosis here. Suppose if you have any other queries, any other doubts, you can ask. So I can discuss about any other differential diagnosis for maybe a 5 minutes. So if you want. CNS in HOS versus TTP. Yeah, good. That's a good question, Shubham. CNS in HOS versus TTP. In the central nervous system, HOS, you have this typical HOS that's called HOS-D plus, and there are a lot of variants in this, and atypical HOS-D minus, and you have TTP, thrombotic thrombocytopenic purpura. You know the mechanism here. Usually this HOS is due to endothelial injury. You know that. So that's the reason why you get HOS. But TTP in general is due to platelet trapping. So that's the mechanism. It's not endothelial injury that happens in TTP. It's usually due to platelet trapping. So CNS manifestation wise, it's very, very common with TTP. It's usually inevitable in case of a thrombotic thrombocytopenic purpura. Usually can happen in case of a atypical HOS. Very common in fact, but extremely rare in case of a typical HOS, in HOS-D plus. So it's very common in case of atypical HOS, as especially complement-related HOS, but inevitable in case of a TTP. So the CNS involvement is very, very important in case of a TTP. Then GIT involvement. Remember, GIT involvement is extremely common in case of a typical HOS. Majority of them will have a bloody diarrhea. There is absolutely no doubt about that. Whereas GIT involvement in case of a atypical HOS is still possible, but rare. In TTP also is still possible, but rare. And this GIT involvement in atypical HOS and TTP occurs as a part of end organ damage. So which is quite common as well. Then what about the kidney failure, renal failure, renal involvement? Renal involvement is extremely common with and very severe with HOS, but it's seen but not so severe in case of a TTP. Usually that's why I told you the serum creatinine generally tends to be more than 1.5 at the time of presentation in case of a HOS, any HOS. That's very, very prominent in case of a HOS. But in TTP, it's unlikely to be prominent, at least at presentation, it will be usually less than 1.5. The platelet counts in HOS generally tends to be a little decent. It will be more than 30,000. I mentioned this already. It's likely to be a little decent. Usually here it will be extremely low. So severe thrombocytopenia will be there in case of a platelet. Bleeding, people might ask about bleeding chance. Bleeding is equal in all this. So you might result in bleeding, but bleeding is generally not so common. And risk of developing a myocardial infarction. Actually, it can happen usually it is very rare in case of a typical HOS. Can happen in case of a atypical HOS, but one of the very common, almost 15 to 20% of the case reports of MI has been occurred with TTP. So it's quite common in case of a thrombotic thrombocytopenic purpura. That is why I mentioned that this patient is very classic and very common case, because many of the TTP patients tend to have a myocardial infarction as well. So our patient did have a myocardial infarction. So MI is quite common in these patients as well. And what else you want to tell? Antibiotics. Treatment wise, let us put the D-dimer PT every day in INR. So this will solve the issue. PT every day INR, it's supposed to be normal in all these conditions. Absolutely no doubt about that. supposed to be completely normal. And if at all you do a Adams 13 activity, it is supposed to be normal in case of HUS, whereas it will be less than 5%. It's grossly decreased in case of a TTP, but remember it is variable. Adams 13 activity is generally not so important because Adams 13 activity levels are highly variable. Even under physiological states, it's highly variable, so it's not something to be completely relied upon. Apart from that, they will have all classical features of TMA. Now, like all these three will have TMA features. That's why we call this as a thrombotic microangiopathy. They will have microangiopathic hemolytic anemia, thrombocytopenia, and end organ damage. Treatment-wise, antibiotics, no, none of this have a role in antibiotics. In fact, antibiotics are contraindicated in this toxin-related HUS. You cannot use antibiotics. Platelet transfusions, no, generally not needed. But remember, unless severe bleeding. Unless the patient is suffering from severe bleeding, there is no role for any platelet transfusions. So if you want to give an FFP or any plasma products, again not indicated because this patient is having a normal coagulation factors, normal coagulation profile that does not warrant this patient to receive fresh frozen plasma and any other plasma products as well. And will you treat with eculizumab? Eculizumab response is seen only with this atypical HUS, that too only if it is complement mediated. Only if complement mediated HUS. There are a lot of other types of atypical HUS, but it's better to avoid the term atypical HUS. But in complement mediated HUS, definitely it will show 100% response. But in other cases, it won't. TTP, it won't respond. Plasma exchange, there is no role in case of a toxin-mediated HUS. If it's a clear-cut children toxin-mediated HUS, plasma exchange doesn't have any role. And here, yes, partially, 50% response with plasma exchange. And here, definite response, almost 100% response if it's a TTP. But remember, plasma exchange is useful, especially in cases with neurological involvement. Especially if the patient is having neurological involvement, plasma exchange is very, very useful in case of a neurological involvement. So apart from that, plasma exchange is rarely useful. But since TTP, neurological involvement is almost inevitable, plasma exchange is 100% responsive. So because usually this is the trial data, so where plasma exchange generally tends to be useful if neurological involvement. I think this should solve a lot of questions. Clear, because I've told you a table. This must solve a lot of questions as well, because these are the areas where you normally get confused, isn't it? Apart from that, remember, TMA means you will see a microangiopathic hemolytic anemia, you will see a thrombocytopenia, you will see a end organ damage. There is no doubt about that. So this is a classic TMA triad and seen in all these patients. So there is no doubt about that. But apart from that, so these are some of the common questions I do get. But remember, most of the time this HUS and TTP diagnosis is usually clinical rather than your laboratory based investigation. This thing diagnosis is usually a clinical diagnosis most of the time. So I think I have covered in detail about this HUS TTP. And most importantly, like many students do ask whether G8 involvement does happen in TTP and HUS or not. Yes, G8 involvement does happen in TTP also, because remember, even though bloody diarrhea is extremely common with this toxin-mediated HUS, but still it can happen in patients with TTP and atypical HUS as well, because as a part of end organ damage. So don't think that bloody diarrhea cannot happen in patients with TTP or atypical HUS. It still can happen in patients with atypical HUS and TTP. So any other questions I can take? So since hematuria is microscopic, how does a child present with acute oliguria? I don't know. So that is due to endothelial injury, man. So if you are referring to this HUS, hemolytic uremic syndrome, so that is due to endothelial injury. Remember, it is glomerular ischemia, isn't it? So whenever you have endothelial injury, this is the one that is going to carry the blood And if the endothelial injury happens and if the capillaries go for occlusion because of the endothelial injury, obviously, like you will have glomerular ischemia, and this is the reason for AK. Because of reduced renal perfusion, obviously you will result in oliguria only. You cannot result in good urine output. So we are not, the hematuria is not the reason for oliguria or renal failure. It's the glomerular ischemia and endothelial damage or platelet trapping causing obstruction to the small vessels. That's why it's called a thrombotic microangiopathy. It causes microclotting in the small vessels. That's why it's called a microangiopathy. It's a small vessel disease. It's not something gross vessel disease. So this is what happens here. Any other questions? If you want, I can take maybe for a couple of minutes. How does child present? Remember, child usually presents typically with typical HOS. I told you, this is the picture that a child usually presents with typical HOS. That's how child definitely presents with. Even though older terminology tells that it's HOS D+, you should not use the term like D+ and D-. But anyways, that's how they really present. A child presents with a history of bloody diarrhea, may or may not have a fever, and they present with renal failure, thrombocytopenia, and microangiopathic hemolytic anemia. That's how a child presents. It's very classic in a child. And usually majority of the children who present with typical HOS, that is HOS D+, usually will be less than 5 years of age. Usually, most common. But even though it can happen in little bit older children also, but majority of the children will be having age group of less than 5 years. Anyone else? Any other question you want me to take? Any other question you want me to take? If there is no CNS involvement, how to differentiate from HOS from autoimmune hemolytic anemia? It's very simple. Autoimmune hemolytic anemia usually will not have cystocytes. No cystocytes. Most of them will be spherocytes. Spherocytes are quite common rather than cystocytes. Number 1 point. Second, autoimmune hemolytic anemia will be DCT positive. Whereas in like in thrombotic thrombocytopenic purpura, you won't have this DCT positivity. MI due to vasculitis. It can happen, but these patients with MI and vasculitis is unlikely to have a normal ESR. This patient will definitely have a grossly elevated ESR, grossly elevated CRP, and this patient is unlikely to have a normal ESR and CRP, obviously. So usually HOS TTP patients generally tend to have a normal ESR and CRP most of the times, unless and until it is it's your connective tissue disorder related TTP where your ESR might be elevated, but apart from that, and vasculitis will have multi-organ involvement. You have other organ involvement also. Other organ involvement, and you have to do a lot of variety of other investigations also. Patient will have a good background, good history will be there. For example, if it's vaginous granulomatosis, you will have a ENT involvement. If it's a Chukstau syndrome, you will have a eosinophilia. So some clue will be there. So this patient doesn't fit into any of these clues. So it's unlikely to be a vasculature. And there is something called a temporal association. In medicine, whenever you be a physician, so I always believe in only two things. One is called temporal association, and second one is common sense. So these are the two things that are very, very important as far as a physician is concerned. So here the temporal association is very clearly with clopidogrel. So there is nothing else that can explain this picture, whatever we had. So even though these are differential diagnosis and good to discuss, but the temporal association is very clearly with clopidogrel, and my common sense also tells that it's unlikely to be due to vasculitis because of the background history I had, and there is no other clues towards a vasculitis, and the patient is not having any feature that is suggestive of autoimmune hemolytic anemia. Any other question? Okay, if there are no other questions, I think we can wind up with the session. And thank you guys. Hope this session was useful. And we'll meet with another YouTube session of the month. And thank you very much, Shubham. So this is a very important clinical case. So that is the reason why like I wanted to discuss. This is a case we have seen like 8 to 10 days ago. So that's why I wanted to discuss. Okay, I think you would have now cleared all the doubts on HOS and TTP to an extent at least, even though this is a very enigmatic disease and you have a lot of other things to be considered. But as far as your clinical practice is concerned, this is more than enough. So let us stop